Welcome, healthcare providers. Today we're focusing on geriatric patient management.
That's right.
Okay, let's start with the basics, something fundamental. Vital signs. Why are they so, tricky to interpret in older adults?
Yes. Vital signs. They can be quite deceptive with age.
How so?
Well, older adults might actually have a normal body temperature.
Even with an infection.
Or even be hypothermic, lower than normal, despite a significant infection. Their tachycardia, the fast heart rate, it can be blunted.
Meaning it doesn't spike like you'd expect?
Precisely. Maybe due to underlying heart issues or, medications they're on. And this is really important. A blood pressure that looks normal
Yeah.
could actually mean hypoperfusion. Not enough blood flow getting to the organs.
Okay, that's a huge point for initial assessment. So if normal isn't always normal, what specific systolic blood pressure, what number should we watch for?
Right.
For hypotension in, say, an elderly trauma patient.
Right. You need a higher threshold here. A systolic blood pressure below 140 millimeters of mercury.
140.
Yes. In patients 70 years and older, that might signal hypotension. It's higher than we use for younger folks, and it needs immediate thought.
So why that higher number? What's the thinking there?
Well, their vascular system often just needs more pressure, to perfuse organs effectively. It's stiffer, less responsive sometimes.
Okay, so we're trained for lower numbers. What's the risk if we miss that 140 mark?
Big risk.
Yeah.
Missing it can mean delayed fluids, inadequate shock management. You might think they're stable when their organs are actually really struggling. That increases complications, even mortality.
Right. A real shift in thinking needed. Okay, moving to another high-stakes area, chest pain. Older patients, they don't always have that classic presentation, do they?
No, definitely not.
So what's a common atypical symptom of acute coronary syndrome, ACS, that, catches people off guard?
Instead of that crushing pain, they might just have shortness of breath.
Just dyspnea.
Yeah, or excessive sweating, diaphoresis, nausea, vomiting, sometimes syncope, just fainting suddenly. Recognizing those is key because, the classic pain might be completely absent. You wait for that, you might delay care dangerously.
And then there's costochondritis, right? That inflammation mimicking ACS. How misleading can chest wall tenderness actually be? Because finding tenderness feels like a reason to, relax a bit.
Oh, it can be very misleading. A huge diagnostic pitfall.
Really?
Yes. Studies show between 6%, maybe up to 8% of actual ACS cases present with chest wall tenderness.
6 to 8%. Wow.
So finding tenderness. It should never, ever be the only reason to dismiss ACS. You have to look at the whole picture, especially in older adults where things are so variable.
Don't anchor on that finding.
Exactly. It's a cognitive trap.
Okay, let's shift to abdominal pain, another area that seems particularly high risk in older patients. What makes it so challenging?
Well, several things pile up. Again, atypical presentations are common.
Right.
Getting a clear history can be tough. Cognitive issues, maybe multiple health problems clouding the picture.
And medications?
Medications can mask symptoms, absolutely. Then lab results might not be as reliable as in younger patients. And on exam, those protective abdominal signs like guarding, they might be decreased.
So less reliable history, masks symptoms, less reliable labs, fewer physical signs. It's like flying blind sometimes.
It feels that way. It really compounds the challenge. You need a high index of suspicion.
So this blunted response theme continues. How does that specifically play out with abdominal pain? What's the biggest pitfall?
Well, the severe, sharp pain a younger person would have might just be vague discomfort in an older adult. Their abs might not tighten up guard as much. Inflammatory markers in the blood might not shoot up dramatically, even with something serious like a perforation.
And the pitfall?
Underestimating the severity. You see a relatively benign exam, maybe labs aren't sky high, and you think it's minor when it's actually critical.
Okay, let's focus on appendicitis. If you miss that, it's bad news. What percentage of older adults don't have the classic signs, like fever or right lower quadrant tenderness?
It's a striking number, about 80%.
80.
Yes, 80% lack the classic triad.
Yeah.
Fever, right lower quadrant tenderness, or that high white blood cell count leukocytosis.
So the textbook picture is often just missing.
Completely missing, which dramatically increases the chance of misdiagnosis. Their inflammatory response just isn't as strong.
And if that diagnosis is delayed, what are the consequences for appendicitis in this group?
Well, the consequences are severe. The mortality rate for geriatric appendicitis is somewhere between 4% and 8%.
That's high.
It is. And perforation rates, the appendix bursting, are reported near 70%.
70% perforation.
Yes, meaning By the time it's caught, it's often a much more complicated, dangerous situation.
Okay. How about mesenteric ischemia? That reduced blood flow to the gut. Is there a key historical clue providers should look for? Something specific?
Yes, there is. It's quite important. For mesenteric venous thrombosis, that's the type with a clot in the veins, half of those patients.
PAF.
Half have a personal or family history of venous thromboembolism.
You mean like a DVT or PE?
Exactly. Deep vein thrombosis or pulmonary embolism. Asking about that history can really point you in the right direction.
That history of clots could be a real key. Why is that history so predictive?
Physiologically, it points to an underlying tendency to form clots too easily, a hypercoagulable state. So if you have an older patient, especially with heart risk factors, and they have severe abdominal pain that seems way worse than the physical exam suggests, asking about prior blood clots, personal or family, should immediately raise your suspicion for mesenteric venous thrombosis. It connects a systemic risk to a local emergency.
Got it. And what about a ruptured AAA, abdominal aortic aneurysm? Do we always see low blood pressure, hypotension in these elderly patients? It feels like you should.
No, absolutely not. And this is critical.
Okay.
Hypotension is absent in 65% of ruptured AAA cases in older patients.
65% don't have low blood pressure.
Correct. So if you're relying only on hypotension to make you think of ruptured AAA, you'll miss a lot of them. Delaying the diagnosis can be fatal.
Why is that? Why no hypotension?
Their body's compensatory mechanisms can sometimes maintain blood pressure longer, even with significant internal bleeding. It masks the severity.
Okay, so 65% without hypotension. That changes everything. If we can't rely on low BP, what should we focus on for a suspected rupture?
You need that high index of suspicion based on age and symptoms.
Yeah.
Sudden, severe abdominal or back pain. Maybe flank bruising, though that's a later sign.
So pain is key, even with stable BP.
Yes, don't wait for shock. A thorough exam and, honestly, a low threshold for urgent imaging are essential. The absence of hypotension is a trap, not a reassurance.
Right. Okay, shifting gears to urinary health, UTIs, urinary tract infections. How common is asymptomatic bacteria, just bacteria in the urine without symptoms in older women?
Oh, it's very common. Up to 20% of older women living independently in the community have it.
1 in 5.
It jumps way up in nursing homes, up to 50%. Half of female nursing home residents might have bacteria in their urine without an actual infection.
50%. Wow. Okay, so given that huge prevalence, what's the big mistake providers make when they see that positive urine test in an older patient?
The biggest mistake is diagnosing a UTI based only on nonspecific symptoms.
Like confusion.
Exactly, like confusion or just generally not doing well, plus a positive urinalysis, but without those specific local urinary symptoms.
Like burning or frequency.
Right, dysuria, frequency. Just having bacteria there, the bacteria itself, often doesn't mean there's an active infection that needs antibiotics.
So we risk overtreating.
Absolutely. Leading to unnecessary antibiotic use, resistance issues, side effects. You really need to look for those specific urinary symptoms before jumping to treatment.
Okay, that's a crucial point for antibiotic stewardship. Let's talk about falls now. Very common, often devastating. What's the leading cause of death from injury in patients over 65?
It's falls.
Falls themselves.
Yes. Falls are the leading cause of injury death in that age group. They carry an 11% overall mortality rate.
11% mortality from a fall. That's staggering.
It really highlights how serious these events are. It's far more than just the immediate physical injury.
So falls aren't just about broken bones. They're the top injury killer over 65. What things, besides just, tripping, contribute to this high mortality? Why are they so complex?
Well, it's often a mix of things. Visual impairment is a big one. Loss of sensation in the feet, peripheral sensation loss. Alcohol use can contribute. Polypharmacy, taking multiple medications.
Side effects, interactions.
Right. Syncope, fainting spells. And something we have to consider, elder abuse can sometimes manifest as unexplained falls or injuries. So a fall assessment needs to be really comprehensive, look at all these potential underlying factors. The fall itself might just be the tip of the iceberg starting a downward spiral.
Given that potential for hidden injuries after a fall, especially head injuries, why is more liberal CT scanning recommended for older patients with head trauma?
It comes down to some concerning statistics. Up to 44% of older patients with a significant head injury.
44%?
Yes. May present without any obvious neurological deficits on your exam. Occult injuries, hidden injuries, are just much more common in this group. Their brain physiology is different.
What makes those hidden injuries so common? The physiology.
As we age, the brain tends to shrink a bit, atrophy. This creates more space between the brain and the skull.
Okay.
So bleeding, like a subdural hematoma, can accumulate more before it causes pressure and noticeable symptoms. Also, those bridging veins between the brain and its covering become more stretched and fragile, easier to tear even with minor trauma.
So the injury can be silent for longer.
Exactly. If you don't image liberally, you risk missing significant bleeds until it's much later, potentially causing more damage or worse outcomes. A seemingly minor fall can cause a major hidden bleed.
Okay, so lower threshold for head CTs. What about fractures after falls? How common are they and what bones usually break?
Fractures happen in about 5 to 10% of falls in older adults.
Okay, 1 in 10, 1 in 20 maybe.
Roughly, yes. For women, forearm fractures are the most frequent. For men, overall, hip fractures are the most common. And hip fractures, as you know, are often devastating.
Leading to loss of independence, yeah. And rib fractures, why are they so much more significant in older patients compared to younger ones? They seem particularly dangerous.
They really are. The mortality rate from rib fractures actually doubles in older patients compared to younger ones.
Doubles.
Yes. And if an older adult has 3 or more rib fractures, that carries roughly a 1 in 5 risk of death.
20% mortality with 3 or more ribs. Why so high?
It's because they often lead to complications like pneumonia or respiratory failure. Pain prevents deep breaths, and coughing, their respiratory reserve is lower to begin with. So it's not just the pain, it's a gateway to life-threatening lung problems.
That puts rib fractures in a whole new light. Okay, this brings us to a tough but really vital topic, elder abuse. What percentage of these cases involve close family members?
It's a very sobering statistic. Nearly half, almost 50% of elder abuse cases are perpetrated by adult children.
Half by their own kids.
Yes. And another 20% are by spouses.
So 70% by children or spouses.
Right. It really underscores that the threat often comes from within the home, from people they trust or depend on.
Those numbers are heartbreaking. It challenges assumptions about who abusers might be. Beyond those stats, what are some subtle signs, maybe nonverbal cues, that might suggest abuse even if the patient isn't saying anything?
You look for things like unexplained injuries, or injuries where the story doesn't quite fit, frequent accidents.
Okay.
Observe the interaction. Is the older patient unusually quiet, withdrawn, maybe fearful when a specific family member is present, hesitant to speak? Also look for sudden changes in finances, poor hygiene, signs of neglect like dehydration, or not having necessary aids like glasses or hearing aids. These subtle things, especially together, should raise a red flag.
So what can we as healthcare providers actually do to increase detection? It feels like it's often missed.
One simple but powerful step is to routinely ask.
Just ask directly.
Yes,
Yeah.
routinely ask older patients about abuse during their evaluation. Do it sensitively, ensure privacy, maybe ask when the family member steps out.
Create that safe space.
Exactly. That direct question can open the door for someone to disclose what's happening, allowing for intervention and support. It requires conscious effort to build it into the routine.
Okay, well, we've covered a lot of ground today. Some really critical insights into geriatric care.
Your attention to these details is absolutely paramount.